Honorable judges, respected panelists and learned audience, very good afternoon to all, and this is a very wonderful day. I am Dr. Chayan Singha. Today I'd like to present a case. The title is What Mind Knows, Eyes Can See. My patient, a 60 years old female who was non-diabetic, normotensive, non-asthmatic, presented to our emergency with the complaints of dyspnea, chest heaviness, and dizziness for the last 6 months. We quickly reviewed the patient, showed uncomfortable with lean and thin body mass. She was sweaty and cold, clammy skin. She has tachycardia with low volume pulse. Blood pressure was 80 by 50 millimeter mercury, pulsus paradoxus. She has tachypnea with raised jugular venous pressure. Her apex beat was impalpable with muffled heart sound. Her SpO2 was normal on room air. Other systemic examination reveals no abnormality. Then we quickly done an ECG which showed low voltage ECG with tachycardia with poor progression of the R wave. The investigation carried out with her, a chest X-ray showed the massive cardiomegaly. And we quickly sending the few investigation, and we do an bedside echo which show there is a swinging motion of the heart, and there is diastolic collapse of the RV and RA was seen, and the pericardial effusion was 48 millimeter. Inferior vena cava was dilated and non-compressible during respiration. And then we immediately pericardiocentesis was done through subxiphoid approach, and around 1000 ml stock-color fluid was drawn. After that, she got massive relief. Then we subsequently to see the etiology, we investigated her accordingly, and pericardial fluid was exudative with normal ADA, gene export was normal, no malignant cell was seen. Then we thought what could be the etiology of this patient. Then we done the rheumatological profile which showed normal, but thyroid profile examination reveals she had overt hypothyroidism. TSOs were more than 150, and anti-TPO antibody and anti-thyroid antibody were positive in high titer. Okay, so this is a case of cardiac tamponade due to autoimmune hypothyroidism. But one thing knocked our mind that regarding the paradoxic phenomena that her lean and thin body mass, and she had persistent hypotension with dizziness. Then we do the basal cortisol and with serum ACTH. Surprisingly, we found that it was both were lower. Other hormonal assay of anterior pituitary showed the normal finding. Then we do and brain imaging, MRI of the brain, show the pituitary stalk was partially seen, and the cavity was filled up to some extent CSF, though, so this is a case of partial empty cella. Then we searched the literature extensively, and there was interesting paper was found, and several case report was found that on recent published in the European Society of Endocrinology, that to see the relationship between empty cella and Hashimoto's thyroiditis, out of 81 patients, 18 was detected Hashimoto's hypothyroidism. So their conclusion is that any patient with partial empty cella and may be caused by Hashimoto's thyroiditis. So their recommendation is that presence of Hashimoto's thyroiditis should be investigated in patient with partial empty cella and vice versa. So our final diagnosis, this is a case of cardiac tamponade due to Hashimoto's thyroiditis with secondary adrenal insufficiency due to partial pituitary insufficiency that is caused by partial empty cella. So she was on thyroxine with steroid with calcium and vitamin D. And we followed the patient. She showed the incredible improvement of her clinical symptom, and biochemical thyroid status was absolutely normal with the replacement. Her ECG was quite better than previous, and chest X-ray was also improved, and echo shows the no pericardial effusion was seen. So my take-home message is that any cardiac emergency should be addressed very sincerely, as successful management of this condition brings an instant magical result. Though cardiac tamponade due to hypothyroidism is a rare entity, but it may happen, we should keep in mind. And any deviation from the classical features of a disease should knock to our mind that whether we are missing something or not. And Hashimoto's thyroiditis and empty cella are the two associations due to an autoimmune insult, and we have to keep in mind. So thank you very much again for your patient sharing.